Yes, doctor, you can.
Okay, I will share the scenario for Dr. June. Yes, so you have got 5 minutes to prepare your points, after which
Okay.
we are going to start it. I forgot to mention the age of the patient. It is 40 years.
Okay.
Okay, so the 5 minutes waiting time is over.
Yes.
And start the timer for you. You have got 10 minutes. You can start now.
Hello. Hello. Good evening.
Good evening.
Yeah. Am I speaking to Mr. Robert Wilson, 40 years old?
Yes,
Okay, so how may I address you?
you can call me by the name of Robert.
Okay. So Robert, I'm here to talk to you about your medical condition. May I know why you are in the hospital?
Well, I felt very unwell. I was sick. I began to vomit. I got a lot of tummy pain with headache. And then I asked one of my friends to take me to the hospital.
Okay. Sorry to hear that, Mr. Robert. And so, what are your expectations from this meeting?
Well, I just want to be well, and I think I'm quite all right now, so I can go home. So, what's your plan to discharge me?
Yeah. So Robert, it is nice to hear that you are feeling all right. But I have a few things here to discuss with you. So from the notes, I'm aware that you have had some tablets of paracetamol overdose. Is that correct?
Well, okay, yes, I had with this problem, right? But I don't want you to share this information with anybody. You know, my wife will come anytime, and I don't want you to tell her anything.
Yes, Mr. Robert. Be very sure that whatever discussion happens here will be very confidential and it will remain confidential. And you are free to share with me your concerns. Is that okay?
Okay.
So just a few brief questions I would like to ask you. How many tablets did you consume?
So I took 20 tablets of 500 milligram paracetamol in one go.
Okay. And did you take it with any other medications or alcohol, anything like that?
I took it with 2 cups of wine, but I didn't take any other medicine with it.
Okay. And were you aware that these medications can cause you harm?
Well, you know, my life is totally miserable right now. I feel my future is dark and I didn't want to live it anymore. That's why I did it.
Yeah. So sorry to hear that. Will help you in this regard, Mr. Robert. Is that okay?
Yeah, but what will you have helped me. I think you've treated me and I'm feeling all right now. So why don't you send me home?
Yeah. So, Mr. Robert, you have still to complete your medication according to the protocol for the overdose that you have taken. So that is why you are means you are being kept in the hospital, and we are bound by certain. We have to complete the medication according to the protocol. Is that okay?
Okay, doctor, but see, I'm responsible for my life. You can't solve my problems. So I will be able to do
Yes,
that once
Mr.
I go back to home.
Yes, Mr. Robert, but given the fact that you had had a large dose of medication, which was an overdose, and you have had stresses in life, multiple stresses. So ideally, in the hospital, you would be seen by a mood specialist within the 3 days of admission, and only then we can discharge you home once we are satisfied that all things are okay. Is that okay?
What, what do you mean a mood specialist will see me?
It is a requirement by the law that you have to be seen by a psychiatrist and that you have to be assessed before in the hospital stay before we discharge you. Is that okay?
How is it gonna help me?
Yeah. So, Mr. Robert, this is just for you to be assessed, and so that such an event doesn't happen in future with you, and they will help you to also deal with the stresses and make you have a positive outlook in life. That is why it is required that we assess you in the hospital before we discharge you.
Well,
Are you with me?
okay, yeah, I can wait for you, but doctor, my wife then can come anytime. I'm really worried that somebody can leak this information to her that I've taken this dose. of the medicine, and we are not already getting along well. We are not compatible for a number of years, and I have decided to be apart now. And
Okay,
it's
sorry.
not on top of my on my financial crisis. I'm facing a lot of this problem. You know, we have got this economic downfall, and I'm working in a bank, and I'm not able to cope with my life.
Yeah, so Mr. Robert, as far as your condition is concerned, will try and help you in this regard. We'll involve the occupational health services and see how they can help you in this financial matters as well as your work related issues. Also, we'll see how with the help of social services how we can help you in your marriage thing. If anything like counseling or something which will help. If not, how we can help you in this regard. But I would like to tell you that be rest assured that we will maintain strict confidentiality as far as disclosing information about your health and why you are here in the hospital. If at all your wife turns up to the hospital, so that you have my word on it that this will be taken care of.
So, what will you tell my wife if she comes to see me?
No, so we can tell her that we don't have the permission from you to share details about your admission to her. So we will tell her about the symptoms that you have and the what treatment we have given, and that you are stable right now. So we will speak to her when she comes. Is that
Okay.
okay?
Okay, I believe that you're going to do that. But when will this doctor come to see me, who has to assess me?
Yeah. So we will assess you within the 3 days of your admission since you are admitted, and then only we'll plan a discharge for you because you are symptomatically better. So we'll try and help you in this regard. Is that okay?
Okay. Yeah. So
Can
I'll
I
just
ask you
wait
a
for
couple
this.
of
Yeah, you can,
yeah?
doctor.
Do you take alcohol, Mr. Robert?
Well, you see, I've faced a lot of stress in my life now, so there are times when I take more of it. I've got like spirits in bottles, or I take vodka. So, and if I'm going out with my friends over weekends, I take it above the recommended limit.
Yeah, so Mr. Roberts, alcohol, what you are taking is above the social limits, and I would advise you to cut down on alcohol. And we will involve this alcohol anonymous groups, and we'll see how they can help you in this regard if that's okay with you. Is that okay?
Yeah, okay. If it's going to help me, then I'll go to that clinic and see them.
Yeah, just
Yeah.
a few more things I would like to tell you. When we plan discharge after the psychiatrist sees you, if you have any symptoms like again having feeling sick or throwing up or some yellow discoloration of the eyes and reduced water works, then I advise you to come back to our ER and we will help you in this regard. Is that okay?
Well, if you have treated me, and then I don't think that I should get the symptoms anymore.
Yeah, we hope so that you don't get any more symptoms.
Yeah.
But just to this for you, will give you leaflets, brochures, and the hospital contact number, so that if you can read more about this condition, and also will involve the respective teams so that they can help you out in this tough times. Is that okay?
Yes, doctor. So there's 1 minute left now.
Do you have any more concerns for me?
Well, yeah, you've told me that you're not going to tell my wife. I have to wait for a doctor to see me on the ward. And but you said that I have to complete this treatment for this overdose. So, yeah, but doctor, I don't feel good about my life.
Sorry, I
Yes,
didn't get you.
I don't feel good about my life. I
Yeah,
did
so
call a friend this morning after I took the tablets, and who brought me to the hospital. But I'm not sure if I'm going to reattempt it. I don't feel good now.
yeah, so this is the precise reason that we will monitor you, and we'll also involve our psychiatric team and see how they can help you in this regard so that you don't you have a positive outlook in life. and they will do a lot of talking therapy with you, and also they will see how medications can be introduced so that they can help you in this stabilizing your mood, and also simultaneously will also involve our social services and occupational health
Yeah,
team to help
your
you in this
time is
regard.
up. Time is up now.
Yes,
Yeah,
ma'am.
you can, yeah, so you can have 1 minute to recollect, or do you just want me to go on to explain the scenario? Because if you see the latest pattern, then you're not going to be getting a viva now. So the examiner questions are absent in this exam. So I'm just going to
Yes,
summarize
you
the
can go
whole
ahead.
scenario. Yeah.
Yes, ma'am.
Okay, so I've just got a few points to tell you, but you've done well. First is that you used the word psychiatrist, which is a jargon, and the best term is mental health specialist.
Okay.
Okay, and I think there were just a point. Some points were missed in to dig out the problem for this patient, as he went on to tell you about the factors which were giving stress. But you had to ask a few more questions, because this is a kind of a scenario in which you can take history, suicidal attempt.
Okay, ma'am.
Then you forgot to ask, how are you feeling now?
Okay.
It can be done in the beginning of the scenario. So we just want to check if the patient has got any more symptoms now.
Okay.
And I think we could stress more on the medical aspect of the management plan, just to be more clear why this patient needs to be in the hospital for safety and health. And so I'm just going to summarize the whole scenario, and this, I hope it will be helpful. And if anybody has got questions, they can write it in the chat box. Okay.
Yes, ma'am.
So now, what is the theme of this scenario? It is a suicidal attempt. So whenever we get this kind of a case, then we start it with greet and introduce, in which you are telling that I am Dr. Dash, one of the doctors in the ward, and you confirm the name and age of the patient. Are you Mr. Robert Wilson, aged 40 years? I'm here to discuss about your condition. Is it all right with you? So we are taking the patient's permission for that. Then perception. So first I want to know, what do you understand about it? Understand about the events which led to your admission in the hospital. So here the patient will tell you a few details that will cover the points that can be asked in the history by us. Like he can tell you why he went to the hospital, but he will not disclose information to you until you reassure your patient that it will stay confidential. So we have to try to tell this to the patient before they bring this point to us in this scenario. That is, we have to ensure confidentiality. I'm here, and you have to sympathize with the patient. I'm sorry that you are in this difficult situation. I can understand you're feeling bad now, and we are here to help you. And I reassure you that this discussion will remain confidential. So then you can ask about the concerns of the patient. Can I ask what is particularly concerning you? So first, confidentiality. Here we went on to the second point, in which we have to tell the patient that this information will not be disclosed to your wife, because he was very worried about that she will come anytime. I don't get along well with her, and I don't want my wife to know about it. So the best approach to this kind of scenario in communication encounters is that address the concern that's raised by the patient, because we have got our own flow of ideas, we have put it down on our paper, but we have to rearrange it in view of our surrogates conversation. So now this point came first, and you said you can tell the patient, I reassure you that your confidentiality will be maintained. If your wife comes to the hospital, we will not disclose the information to her without your consent. We can simply inform her that you felt unwell, so you were brought to the hospital, and you are feeling well after the treatment. This is going to satisfy your surrogate. So let's come to the next point. You can tell the patient the medical aspect of your management plan that will enable this surrogate to understand why is it important to stay in the hospital. So you can say that, I know it's important for you to go home to sort out different matters, but if we keep you in the hospital, we can treat and monitor you as we are worried about your health and safety. You have taken a medicine which can produce toxic effects on the liver and kidney if it's in high dose. We have measured the blood levels of this medicine. It was high, which indicated that it should be treated. So we gave the antidote to you. And this timely treatment is life-saving. Now we want you to stay in hospital so we can monitor your vital signs. That is your blood pressure, heart rate, the oxygen levels, and alertness level. We will be doing blood tests to check the functions of your vital organs, that is liver and kidney. Plus, it will help us to monitor the levels of the drug. And it will not be possible if you go home. So now you have covered the medical aspect of this scenario. Now we come to the legal aspect of the scenario, which is very significant. And here you have to dig out the matter now. We want to know if we have got predictors of a future attempt. For example, our surrogate can articulate a wish to be dead. So you can here take a short history. We usually discourage history in communication encounters, but suicidal attempt is one of the scenarios, is a scenario in which we can take it. So you can say, what did you take? And what was the number and dose of the tablets? Did you take it with water or alcohol? Did you take a medicine or drug with it? Did you plan it? Did you write a note? So you were alone? Did you lock the room? Did you tell anyone? How do you feel about it now? Do you feel that you're going to do it again? So now we want to ask if he planned it in a manner that no one could intervene, because that is a dangerous point. And if he is telling us about abuse of drug or alcohol, then here we can fix the problem on the spot by telling him that we have got special clinics where you can be referred to help you with this problem, because it is bad for your health. Now we want to explore the reasons for this act. So we can ask the patient, I want to know if you have got stress factors in your life. So when the patient is talking to you, he will cover many points which we were intending to ask in our history. But if there are a few points missed in the patient's conversation, then we can cover it by asking. So if the patient shares the problem, then we can just talk in the relevant way. Like we can refer you, or like, I'm sorry to hear that, and we will try our best to help you. Can I ask, did you previously see a mental health specialist team for problems with your mood? Is it the first time that you have done it? Because we have to find out a past history of depression or suicide. Do you know somebody in the family who had mood problems or suicide case or suicide attempts? Because if there is a family history, then it is also a risk factor. Now, we want to know if there is a protective factor in this patient's life, if he has got support in family or friends. And if we assess that it is a high risk patient, we will know that we cannot discharge this patient without a psychiatrist review. And when there is a depressive illness underlying this problem, then it affects the patient's ability to judge and decide. So mental capacity is absent. Psychiatrist review must be done, or patient has not got mental capacity because it's a case of a suicidal attempt. So we cannot let him go without that. But don't tell the patient that I'm going to detain you. If the patient is not willing to stay, you can tell the patient that, okay, I'm sorry that you're feeling this way. I will speak with my consultant who will talk to you in more detail about it. So this brings us to the legal aspect. You can also throw light on symptoms of depression. That if there are factors which bring stress in life, it can affect your diet and sleep. So did you get problems with that? And you have also covered about alcohol and drug. And how is your mood? What is your approach towards the life? So let's go to the most important point in this scenario, that we will request a mental health specialist team to see you, because they will decide if you need a treatment in the hospital or if you can be discharged to home. They will plan your management next steps. So this will help you to cope with the stress factors in your life. And they can advise you counseling sessions or relaxation therapies. And there are also special organizations that can help you with your finances if you are in a trouble. So if they discharge you, then they will follow up with you in the clinic. Plus, they will put a community level supportive network in place who will take care of your health and safety after you go home. It brings me to one point. Can I ask you, do you want us to share this information with your GP, as this is your first point of contact? So if the patient does not want to share this with the GP, then it's fine. Okay. We will not share it with your GP without your consent. But of course, we have to refer this patient to the psychiatry team. We hold the authority to put a Section 522 in place, which intends to keep the patient in the hospital until they receive a psychiatric review, because we are bound to do it by law. Because if the patient goes home, he may attempt suicide again. So we are worried about the safety of our patient. So it is the psychiatry team who can detain the patient for observation and treatment for the medical illness if it is required. So they are going to plan the next steps, but we have to keep this patient in hospital until they come to see him. So this is the main thing when you have got a communication encounter about a suicide attempt. What are your points? Greet and introduce, permission and perception, sympathy and empathy, ideas and concerns, confidentiality. You have to make sure that we will maintain your confidentiality. We are here to help you. We are sorry that you are in this situation. How are you feeling now? We want to make sure that he hasn't got any more symptoms. And then you address the patient's concern. For example, he brought this question that he doesn't, if the wife comes, then he doesn't want her to know about it. So you address that. Then you explain the medical significance of the hospital stay. Then you took a short history. The patient will already share a few details with you, but if there's anything left, you can cover it in your history. And we have talked about that. It is the history of the suicidal attempt. What were the events over here? We throw light on the past history, family history, and drug history with alcohol, stress factors, and about depression. We ask a few questions. And in the end, it's very important to tell the patient that he has to stay in hospital until the mental health specialist team reviews him. We can't let him go without that, and then we can ask if he wants us to share this information with the GP. Now, you have got 10 minutes. I know it's challenging to contain all of this talk within this short period of time. We have to let the surrogate talk to us, and we have to cover the main points which are expected by the examiner. So I was elaborating the scenario, that's why I talked in detail. But when you are practicing this scenario, try to keep the sentences brief and meaningful. So if you practice it, it won't be hard. You will do it. I've covered the scenario. If anybody has got questions, they're welcome to ask.
Ma'am, just one question. So how long
Yes.
do they keep in the hospital? 3 days?
Yes,
For
it
the
is 72 hours.
Okay.
Yeah,
Thank you.
within which patient should be reviewed by the psychiatry team.
Okay, thank you.
Yeah.
I have a
And then-
question. If patient refuses to stay in hospital,
I'm
how
sorry.
can I deal with this patient? If patient refuses to stay in hospital, how can I deal?
Yes, yes. So here we will not tell the patient that we are going to detain you, because this is a patient who has not got the mental capacity to take decision in terms of healthcare now, because this is a person who has tried to finish their life because they were in a very severe state of depression, which can affect the ability to process and judge. So we know that this patient is not capacitous. We can't let them go home, but we will say, I will speak with my consultant to talk to you. And we will make sure that the specialist team comes up to review you, because we cannot send you home by law without this review, as we are worried about your health and safety. So if the surrogate is very difficult with you, and they keep asking you that I have to go home, but you have to put your foot down on it, that we can't let you go, and you just have to stay calm. You can use just polite words, you can talk in a formal way and tell the patient, why are you not able to do it by law? I hope it's
Assalamu alaikum,
clear.
doctor. One question, please. So if the
Walaikum
patient
salam.
insists to know how much he should stay in hospital, so what is the best answer?
So here we can say that our specialist team usually reviews you within 72 hours, and we will make sure that it is done soon, so that the next steps in your management plan can be decided.
So 72 hours. We cannot give time frame like from 3 to 7
Yeah,
days.
because no, we cannot give a very fixed frame of time.
Fixed.
But
Okay, thank you.
the patient will usually be concerned about this specialist who has to come to see him. So here we have to tell him that it's usually within 72 hours. And we had a question that can we ask why he doesn't want her wife to know about the event? Can we encourage him to tell her so that he can have support from his wife in future? Okay, if
thank you.
there is, yeah, if there is a suicidal attempt is a very sensitive case, and here we have to just maintain the confidentiality. So if he's asking us, don't tell my wife, we will respect his wish. We will say, okay, we won't do that. Yeah, just say that, okay, if she comes to the hospital, we will not disclose any more information to her without your consent. I think we will not go down this line now. And then you have to ask a lot. You have to tell him a lot within 10 minutes. And cannot we ask if there is any reason you don't want to share this news with your wife? So it will be, I think, kind of a clue that he doesn't get along well, or he's scared of the wife, or he doesn't want this to know because it's going to increase the rifts in the house. You can ask, why don't you want your wife to know about it? He will tell you why, what is the problem. underlying this situation. And then you can say that, okay, we will maintain your confidentiality and we will not share any information with her because your examiner wants to hear that. And yes, GP, we will ask the patient that, is it okay if we share this information with your GP? Because who is the first point of contact if you've got a health problem? So, but if the patient refuses it, then it's fine. We will not inform the GP. But if the patient is okay with it, then we can share this information with the GP. So if there isn't any other question, I think we can move on to our next case. Dr. Huda was going to carry out a clinical consultation today.
Doctor, I have one question
Yeah.
regarding that, as you told, regarding involving the law, right? So how would you address to the patient? How would you tell to the patient actually?
How will we word it?
Yes, exactly.
Yes. Yeah, so we will say that it is our legal duty
Okay.
to ensure that you are seen by the specialist, by the mental health specialist team before we send you home, because they are going to decide the next steps in your management. They will see if you need treatment in hospital or you can be sent home with a plan of follow-up in the community.
Okay, got it. Thank you. That's my
You're
question.
welcome. So is it okay if we move on to the next case, as will be done with Dr. Huda? And if you still have questions for this scenario, you can write it in the chat box and we can talk about it in the end. Dr. Huda, I'm done with this
Yes.
case, so I think
Yes.
you can start now.
Okay. So can you make me host? Then I will share this.
Okay, I've got to make you a host. Okay, I've done that.
So I think who will do the case? I think a few candidate has. Anyone want to do the case, they can do it. I think Joel has told me before, so he already done the case. So it's a very easy case and very common exam case. So anyone want to take the case, you can take
I
it.
want to do, sir.
Okay, Dr. Niga. Just a minute. Just a minute. Okay. Just give me 1 minute. Dr. Nigar, you have seen the case? Hello, Dr. Nigar. Dr. Nigar, we can start.
Yes, sir.
Okay, start.
Good afternoon. My name is Dr. Nigar Ansari. I'm one of the doctor in the clinic. Is this Mrs. Julia Lupin, 35-year-old?
Yes, doctor.
Nice to meet you, Mrs. Lupin. How should I address you?
You can say me, Mrs. Julia, doctor.
Okay, Mrs. Julia. Today we are here to discuss about your medical condition. I will examine you afterwards. Will that be fine?
Yes, doctor.
I may take some notes in between. Be assured those will be confidential. Okay.
Okay.
Okay. Please tell me what brings you here today.
Yes, doctor. I have some sort of gritty eyes, doctor, and I
Mhm.
noticed recently that I have some sort of vision problem also. For sometimes, for few seconds, I'm not able to see things clearly, doctor.
Okay, I'm really sorry to hear about your suffering. We'll definitely find the cause for it and treat you accordingly. Okay, since when you are noticing this grittiness in your eyes, could you please tell me?
Yes, doctor. It is there for last 3 months, doctor.
Okay, and before 3 months, anytime you have similar problem earlier?
No, doctor.
Okay, and since last 3 months, there is grittiness in the eyes. Is it increasing?
Yes, doctor. It started gradually, and over the time, it is getting worse, doctor.
Okay, and is there anything in particular which makes it worst?
Nothing, doctor. I did not notice anything, doctor.
It is same in the, like throughout the days, in the morning, in the evening, same?
Yes, doctor.
Okay, and it's something which helps you out in this problem?
Nothing, doctor.
Okay. We'll come to your problem with the vision. What exactly you are having at that time? Like you're saying there is visual disturbances. Could you please tell me more about it?
Yes, doctor. For a few seconds, doctor, I can see things slightly blurred, doctor. But when I blink my eyes several times, then it's become okay, doctor.
Okay. Okay. And do you notice any problem to see at like far things, or it's a near thing which you are having problem to see with?
No, doctor. I see things very clearly. Only for
Okay.
few seconds. Sometimes
Only for
I
few
have some
seconds.
sort of blurring of vision. When I blink my eyes or I close my eyes several times, it's become okay, doctor.
Sure, sure. Okay. Okay. Do you have any double vision anytime?
Sometimes, doctor, I notice it for last 1 month. Not always, but sometimes I see things double also, doctor.
Okay. Is it in particular direction you are having that problem? Like when you
No,
see in a
doctor. No,
okay. When
doctor.
you
In any
okay.
direction, doctor.
Okay. And when you close one of your eyes, that double vision backs to normal. Did you notice
No,
that?
doctor. No, doctor. I try to do it, but I don't think it's helping me, doctor, at all.
I'm really sorry to hear that. And do you have problem in the color vision as well? Like you're not able to appreciate colors properly.
No, doctor. I can appreciate color, doctor.
Okay. And is there any bumping into the objects when you're walking, or difficulty in parking cars?
No, doctor.
Any problem to see the straight line, they're appearing distorted to you, something like
No,
that?
doctor. No, doctor.
Any headache along with these things?
No, doctor.
Okay. And this problem with the vision is there along with since 3 months only, right?
Yes, doctor.
Okay. Okay. Just to ask few more questions regarding your health, will that be fine?
Yes, doctor.
Did you notice any shakiness in your hands?
No, doctor.
Any weight changes for you recently?
No, doctor.
Any racing, pacing of the heart?
No, doctor.
Any increased bowel work? Have you noticed, or any blood in the bowel work?
No, doctor.
Okay. Is there any problem? Is there any surgery done for you earlier?
Yes, doctor.
Okay. Could you please tell me about it?
Actually, doctor, I have some sort of neck gland problem, doctor. It was overactive, and they did
Okay.
the surgery, doctor, I think 1 year back.
Okay. Okay. And after that, sorry, thank you for sharing this information. After that, you were okay. You were started on some medications after that.
Yes, doctor, they started me on the medication, doctor.
Okay. And did you notice any new swelling in the neck after that in recent few months?
No, doctor.
Okay. Sure. And can you show me your medication list right now?
Yes, doctor, I can show you the medication list, doctor.
Okay, sure. Okay, this Novomix, you're having raised blood sugar problem.
Yes, doctor, for a long time I have raised blood sugar also, doctor.
Okay, since when you're having that problem?
I think it is for last 5 years, doctor.
Okay, okay. And was there any medication which was started initially, or we directly started this injection for
No,
you?
doctor, they started me directly the insulin, doctor, this injection.
Okay, sure, sure. Okay, just to know few question more. Okay, sorry to ask this question. These are little personal. What about your periods? Are they normal?
Yes, doctor.
Okay, and when was your last period?
I think, doctor, 6 or 7 days back.
Okay, and was there any recent pregnancy in previous few months or years?
No, doctor.
Okay, are you on any birth control pills?
No, doctor.
Okay, sure. And what about any raised body temperature recently? Any lumps or bumps anywhere in the body?
No, doctor.
Okay, and sure. Did you anyone told you that you're looking paler than before?
No, doctor. No one has told me like that.
Okay. Any giddiness when you're getting up from the sitting position?
No, doctor.
Any skin changes, rashes, or darkening of skin?
No, doctor.
Sure. Okay. And what about your mood? Is that fine?
Yes, doctor. My mood is okay, doctor.
Okay. Apart from this problem of the thyroid and this sugar problem, any other medical illness that I should be aware of?
No, doctor. Otherwise, I don't have any long-term illness.
Any recent hospital admission? Any procedure done for you?
No, doctor. Apart from this surgery 1 year back, I did not went for any procedure or surgery. Doctor.
Sure. And apart from this medication, any other medication you're taking? Any over-the-counter medication or herbal preparation?
No, doctor.
Any medication recently stopped for you?
No, doctor.
Sorry to ask this question. Any party or recreational drug?
No, doctor.
Sure. And is there any family problem of glands, like which is running in the family you have? If you can share.
No, doctor. My mother had low blood count and she is taking some sort of injection every month for that.
Okay. Was it low? Okay. It's for to increase the blood number of blood she's taking.
Yes, doctor. She has some sort of. They told that their blood count is low. The hemoglobin level was low, and then they
Okay.
did some test, and they started injection, doctor, every month.
Sure.
She used to take.
Okay. Sure. Okay. I would like to examine you. Will that be fine?
Yes, doctor. You can examine.
And I may ask you some history in between. Okay.
Yes, doctor. You can.
Okay. I'll start with the hand of the patient first. I'll be asking the patient to outstretch the hand in front of me and be looking for the tremors. If they're visible.
No.
If they are not visible, I'll put the paper on that and just want to check, reassure that again.
Okay, so there is no tremor.
I'll be checking for the nails for any thyroid acropathy, any
No,
skin
nothing
changes,
is-
any
no.
sweating in the hands.
No.
Okay. Now I'll like to check the pulse of the patient. Is it regular?
Yes, pulse is regular, same like outside.
Blood pressure is regular.
Blood pressure.
Sorry, blood pressure. Any
Normal.
postural drop?
No.
Okay. Now I'll be checking, asking the patient, can you please lift your hands for me? And I'll be checking the power of the proximal muscle in the shoulder joint.
So there is no proximal myopathy.
Okay. Now I would like to check your eyes, Mrs. Julia. Will that be fine?
Yes, doctor. You can.
Okay. First of all, I'll be checking the eyes. I'll be doing the inspection of the eyes. At that time, I'm looking front. I can see there is proptosis in the eyes, and I'll go and lateral aspect to see any exposure of the cornea outside the lid as well. Lid retraction. I'll ask to check for the lid lag as well. I'll ask the patient to follow my fingers up and down, and I'll check for the lid lag. Now I'll be going ahead on the back of the patient and ask the patient to extend the neck first to see for any proptosis from their side as well.
Very good.
Now I'll be checking because I'm at the back right now, I'll be checking for the thyroid gland itself at this moment of time. Any neck swelling first there?
No neck swelling.
Then I can see the scar over there. I'll just palpate from my hands from behind if there is any swelling which I can feel. If I'm not able to feel, I'll offer a glass of water to just swallow or drink.
Okay. So there is no swelling is there.
Okay, sure. Then I'll be coming in front again. I'll be checking the visual acuity of the patient. I'll be standing just behind my chair and ask the patient to count the fingers.
So
Okay.
visual acuity is normal.
Okay, now I'll be checking the extraocular movement of the patient. Miss Julia, please keep your head straight and follow my fingers with the help of your eyes. And if anytime you can get double vision, please let me know. So I'll be checking for the double vision simultaneously along with the extraocular movements.
Excellent, very good. So she is telling that right now she has some sort of double vision.
Okay, sure. And I'll ask to close the eyes and check if the double vision goes off.
No.
Okay, sure. I would like to offer fundoscopy at this moment.
So examiner told you no need.
Okay, I'll be checking for the perirectus of the eyes, and now I'll go for to see the oral mucosa if there is abnormality there.
Oral mucosa, no, doctor.
Okay, then I'll be checking for the heart. I'll be going to check for the heart of the patient. Any auscultate the heart to see any murmur over there.
So no murmur is there.
I'll be auscultating the lungs basis to see any crepitations.
So you are examining the lung basis and there is no crepitation.
Okay. Okay. Now I'll be going to check for the lower limb. Is there any peritibial myxedema or pedal edema in the patient?
So no peritibial myxedema or edema is there.
Okay. Mrs. Julia, do you smoke? Sorry to ask this question. I know it's personal, but it's really important to understand your condition.
Yes, doctor, I smoke, doctor.
How many sticks for how many years?
Doctor, 5 sticks per day for last 15 years, doctor.
I would like to say that Miss Julia, smoking is not good for your health. It will deteriorate your condition and your eye problem as well. So we will refer you to the smoking cessation center who can help you in this regard. Will that be fine?
Yes, doctor.
Do you drink alcohol?
No, doctor.
What about job? What do you do for living?
2 minutes left. Doctor, I am a teacher, doctor.
Okay. Is this affecting your job?
Not as such, doctor, but everyone is asking me that my eyes look slightly, doctor, prominent. So I'm a bit worried, and sometimes I see things double, doctor, also. So I'm
I
a bit
appreciate.
worried about this.
Yeah, I really appreciate that. What about driving? Do you drive?
Yes, doctor, I drive.
I would suggest you to stop driving because it's not safe for you. Okay. So please tell me, what are your concerns?
Yes, doctor, why I have this weakness in my eyes, doctor? Is I am having some sort of bug infection, doctor?
I appreciate your concern, Miss Julia. It is not a bug infection. Rather than that, it is associated with a gland problem which you had earlier. Okay, and because of which there is abnormal soft tissue growth around the eyes that is causing you this problem. Okay, and we'd like to do few tests and imaging to confirm this. Any other concerns?
Yes, doctor. So, doctor, is it a curable condition, doctor?
Okay, this I understand that you're anxious about it. I would like to say that it is unlikely to be a curable condition. Okay, because it is a soft tissue problem over there. Okay, so we will start you on treatment. We will involve the eye specialist doctor who will check you in detail, and we will start you on some medication which will help to control your symptoms, but it is unlikely that it will revert back completely. Okay, any other concerns you are having?
Yes, doctor. So, are you going to start me some sort of medication, doctor?
Yes, after the consultation with the medical team, we will form a medical team for you who will help. We will decide in that, and we will start you on some medications and some protective effect also. Like you have to follow some protective things, like you are supposed to wear black glasses so you should not hamper your vision, and at night you should be closing your eyes or wearing something so that it should not be any problem with your vision after that. Okay.
So, doctor,
and I would like to, yeah.
So doctor, in future I can lose my sight also, doctor, vision.
Okay, I understand your concern. Okay, so we want to admit you at this moment and start the treatment accordingly. So to prevent that bad outcome to occur, but there is a possibility that rarely it could lead to that to permanent loss of vision as well. But we are here to support you in this regard. We will admit you and we'll start the treatment as early as possible so you don't have the bad outcome. Okay.
Okay, doctor.
Any other concerns?
No, doctor. Thank you so much, doctor.
Okay, here is the leaflet which I want to provide it to you, which you can understand more about this condition. It is called as Graves' disease, which is of, I'm sorry, I just forgot to mention that name
No
earlier.
problem.
Yeah, sorry. Yeah.
Mhm.
Is the time there, sir?
No, time already finished. No problem. It's okay. So, what's your diagnosis, doctor?
This patient is suffering from Graves' ophthalmopathy. This is on the background of the history of surgery done prior in respect to that for the thyroid surgery. Also, this patient is having type 1 diabetes mellitus mostly. So this fits in that diagnosis, sir.
Okay. So he has a gritty eyes. His main complaint is that. So,
Yes, sir.
okay. So, what might be the other differential for that?
The other differential for the grittiness of the eyes could be Sjogren's syndrome, sir. There could be yeah, that is the main important differential diagnosis, or any scleritis. Yes, sir.
Very good. Means local symptoms you have to.
Local symptom. Yes.
Local symptoms. Very good. And any connective tissue disease, including Sjogren, and one another sarcoidosis.
Yes. Okay.
So these are the sarcoidosis. Sarcoidosis also can cause infiltration. So of the lacrimal gland. So how to rule out? It's not due to sarcoidosis or Sjogren.
For the Sjogren, sir, we need to ask a question regarding dryness of mouth and arthralgia, arthritis in the patient, along with B symptoms.
So only one question is more than enough. Do you have any dryness of your mouth? So rule out Sjogren.
Actually, sir, I have written that, but I forgot to ask.
No problem. It's okay. So, so it's okay. Means his main complaint is the gritty eyes. Okay. So first, do you have any dryness in your mouth? No. Rule out Sjogren. Okay.
Yes,
You will see the patient. There is no parotid enlargement. Okay. Okay. So there is no parotid enlargement. So for sarcoidosis, you can just simply ask, do you have any cough more than any?
Okay, sir.
Okay. So it will go with sarcoidosis also. Okay. And any rash anywhere you already asked. So erythema nodosum is also common. So no rash, no cough. Usually rule out sarcoidosis. Clear, doctor?
Yes, sir. Yes.
Very good. Very good. And localized symptoms is must. Do you have any discharge? Do you have any redness in your eyes? Okay. So these are the things. Okay. Very good. So how you will investigate and manage this?
Okay, I will for the investigation, I would like to first do some basic investigation that will include CBC, ESR, CRP, liver function test, kidney function test. I would like to go ahead to do a thyroid function test along with anti-TPO antibodies to confirm my diagnosis. Then I would like to go ahead with a complete ophthalmic examination by an eye specialist doctor again. That is required in this situation. We need to do an B scan for the eyes. We have to go ahead to check for she is diabetic, so we need to confirm the recent insulin levels, recent HbA1c of the patient that we need to take care of as well. And after that, to rule out other problems, like with respect to complication of diabetes, we have to go ahead to do complete lipid profile, urine for proteins that we need to carry out, sir. Yeah.
Any specific test for thyroid ophthalmopathy?
Thyroid ophthalmopathy, B scan we do some else, I don't know. MRI with optic cuts maybe.
No,
I'm not
no,
sure.
there is no test. So there is no test.
It's a clinical diagnosis. It's a clinical thyroid ophthalmopathy is a clinical diagnosis.
Very good.
Yes.
So if examiner will tell you, tell me the investigation. So first you will tell that the thyroid ophthalmopathy is a clinical diagnosis. Okay.
Yes, sir.
However, I will do the test to find out the thyroid function or thyroid status at this moment, and then I will do the scan, different scan to know the why there is a proptosis is there. Okay.
Yes.
Very good. So orbital imaging you will do. Okay. And MRI of the orbit. Clear, doctor?
Yes, sir.
And TSH receptor antibody.
TSH receptor antibodies.
Very good. Okay. So tell me the differential diagnosis of thyroid ophthalmopathy.
Differential diagnosis of thyroid ophthalmopathy will include any sorry, myasthenia gravis could be one of the differential.
Very good,
There could be
excellent.
differential of
So how you will-
endophthalmitis.
So
Sorry,
how
sir.
you will differentiate? How you will differentiate with thyroid ophthalmopathy? Myasthenia gravis?
Sir, in the history, I asked regarding variation at the time of day or night, any fatigability at that time. And at the time of examination also, when I was checking for the lid lag, if there is a weakness, it will be prominent at that time, sir.
So there will be ptosis.
Ptosis will be there.
Ptosis.
Yes.
It is
Yeah,
totally
ptosis will-
different. Is opposite
Okay.
to the ophthalmopathy. Very good. Any other
Okay.
differential?
Patient case of cortical venous sinus thrombosis could be there with the
Very good.
proptosis and ophthalmoplegia. That could be another differentials. Sarcoidosis, as we discussed recently, just now, that could be another differential. Any tumor which is there or superior orbital fissure syndromes, that could be a
Very good.
differentials. Yeah.
Excellent. So all these are usually unilateral.
Yes, sir.
Okay. Very good. So you will tell the name and tell that usually they are unilateral.
These are the unilateral. Yes, sir.
Unilateral. Very good. And usually they do not have lid retraction. Okay. Though
Okay,
it's
sir.
a tumor, but they will usually not have. If it is a
Yes, sir.
cellulitis, it could be tender.
It
Okay?
could be, yes, sir.
Tender. Very good.
And
So-
ophthalmitis or cellulitis could be a
Very
possibility.
good. So how you will manage this case?
I would like to, at this moment of time, patient is having problem with the double vision and there is blurring of vision in between as well. So I would like to offer the admission to this patient. I would like to form a multidisciplinary team, and with the help of the ophthalmologist and the endocrine doctor, I would like to start the patient on medication. This patient need to be started. First of all, lifestyle modification need to be done. Patient should be stop smoking. That is really important. Secondly, eye protective measures should be used for the patient to avoid any corneal
Very good.
ulcerations.
Very
Then patient may need to start on steroid, but the decision will be taken by the multidisciplinary team.
Okay, very good. Excellent. Okay. So here, why you think that she required hospital admission?
Sir, because there was distortion of vision and double visions were there in the patient. So because of that, there could be a.
Why? Where is the distortion of the vision?
She said intermittently there is problem with the vision.
So
That's
that
why
is
there is a.
that is the dryness of the due to the gritty eyes.
Okay.
So
Okay.
the dryness,
Okay.
usually they have a transient blurring of the vision for few
Okay.
seconds, and once
Okay.
they will blink twice or thrice, it will be okay. So she is
Okay,
telling, when I blink my eyes, then my vision goes okay. Okay.
Okay.
So there is no need for admission.
Okay, sir.
Okay, very good. Otherwise, excellent, doctor. So you did very well. Okay. And
Yes, sir.
last, the surgical treatment. Okay.
Surgical. Yes, sir.
Surgical treatment. Okay. So what are the medical emergency in case of thyroid ophthalmopathy?
For the medical emergencies, a patient presenting with any corneal ulceration,
Excellent.
uh,
Very good.
at that time, if there is distortion
So
of
what
the
will be
vision
the
in the way
features?
of crooked, sorry, sir.
So, what will be the features of corneal ulceration or abrasion?
There will be features of photophobia. There will be redness of the
Excellent.
eyes.
Very
So
good.
that will be the main problem if the patient
So
is
you
having.
have to ask for that also. Okay.
Yes.
Very good. And when you will examine, you will also examine for that. But you have to
Yes,
ask
sir.
for it. Okay. Excellent.
Yes.
And optic nerve compression.
Compression, complete loss of
Okay.
vision in the patient or blurring. That will be distortion of the single crooked line will be appear as a crooked. Isn't it, sir?
Very good. And what is the earliest features? Color vision.
Color vision, loss of color vision.
Color
Yeah.
vision. So when you will examine also, you will examine for the color vision. You will tell the examiner, I need a
Okay.
SARA chart for color vision.
Okay.
Okay, very good.
Sir, yes, sir.
So, yeah. So I think overall you did very well. Okay. Only clinical judgment you will lose some mark. Okay, and examination. Otherwise, history-wise, everything was okay, doctor. Local eye symptoms you did not ask. You asked me for the color vision. Very good, excellent, doctor. So these are the very good point you did. Otherwise, excellent, doctor. You took a very good history. Okay. So everyone did some mistake. It is no one without can say that I did excellent. Okay, without any mistake. But these are not big mistake. Okay, so only thing when you are doing the examination. So main examination you have to know that in thyroid ophthalmopathy I have to examine eye very well.
Yes.
Okay. Okay. So the way you examine was okay. Local examination of the eyes you have to do. So you did well. You look for lid lag, lid retraction. Okay, proptosis you have seen. Excellent. Okay. And then you check the color vision. Very good. You have to ask for that. I would like to check color vision by Ishara chart. Okay, visual acuity. And then you have to check check the H-shape movement. Excellent. You have to do accommodation also.
Okay.
Okay, because accommodation are impaired in case of thyroid abnormality. And
Okay, sir.
one another medical emergency you forget to check is the pupillary light reflex for
Okay, sir.
related apparent pupillary defect. Any related apparent pupillary defect, it's a medical emergency.
Yes, sir.
Okay, very good. And you did the fundus examination. Excellent. Fundus examination for optic atrophy
Optic atrophy or
or
diabetic retinopathy as well in this
and
patient.
optic swelling if it is a
Yes, sir.
early signs. Okay.
Yes, sir.
Otherwise, excellent, doctor. And nothing I have to add. You stop driving. Very good. So these are the common mistakes candidates are doing, but you did well overall.
Okay,
Okay.
sir.
So the clinical judgment you might lose you will be become borderline. Otherwise, everything was okay because this patient don't require admission.
Okay.
Okay. Otherwise, you did well, doctor.
Yes, sir.
Okay, so we will see means how to do this case. I make some slide for all of you. So just we'll try to do it, how to do the case. So then you will also have an idea that what are the mistakes you did. Okay, so I think Dr. Ansari did well. Most of the thing she asked me it is progressive or not, asymmetrical, double vision in any direction. Okay, so she is able to do it very well. Color vision, visual loss, blurring of vision, night vision, headache. Okay. General health questions she asked me and she did very well and she confirmed the thyroid status. So she is aware about that how is the patient thyroid status. Okay. Recently in exam last year, one thyroid ophthalmopathy came with weight gain. So don't get confused.
Yes, sir.
Okay. So they are giving the features of hypothyroidism. So don't be disheartened initially that maybe I am losing the case. No. So directly go the way you did very well. You early go to the past history. If you are finding that this lady has euthyroid or hypothyroid features, early go to the past history to find out there might be the cause there.
Yes, sir.
Okay. And then you will look for autoimmune association. So you ask me for additions, okay, connective tissue disease, vitiligo, you can check it by examination also. No need to ask because you don't have
Yes,
the
sir.
time. A red flag, most of the red flag you did very well. Okay.
Yes.
DD of the gritty eyes. So
Sjogren's.
Sjogren's, sarcoidosis, Bell's palsy will be visible. So
Yes, sir.
once you will see, you know, no need to ask any question. Okay, past history, you have to look for any autoimmune disorder, thyroidectomy. So you find it that there might be thyroidectomy. If there is no thyroidectomy scar, you must ask for any radioiodine.
Radioiodine therapy.
Okay. So you should not believe that there is no thyroid scar and patient is euthyroid. How it can possible that patient is having thyroid ophthalmopathy. So you have to ask that have you gone through any radioiodine therapy? Okay. And then the medication you did very well. Family history you asked me, excellent, doctor. Smoking you advised me to stop it, excellent. Stop driving. So most of the thing you did well. How to examine? So you examine for the lid retraction, proptosis, goiter was not there, parotid swelling you have to look for. Okay, acropathy, the way you did Ansari very well, excellent, Dr. Niyar. Arm, BP, proximal myopathy you did. Eyes, there are the 4 examination you have to do it. So eye movement and the lid. So you did it. Okay. So lid retraction, lid lag, and usually they will have asymmetrical limitation of the eye movement. Okay. And you check for the proptosis. Okay. Then you need to rule out optic nerve compression. So visual acuity, visual color vision,
Television.
reflex. Okay. So there might be early features, disc swelling, late will be optic atrophy. Then you have to look for corneal exposure, the red flag. Okay. So how to check for the corneal exposure? So you will tell the patient, can you close your eyes fully? Okay.
Mm-hmm.
Okay. So if he is able to close his eye fully, it means while sleeping, his eye will be closed and he is
Closed.
not at risk of developing corneal
Corneal ulcer.
exposure. And the symptoms will be photophobia and pain in the eyes. Okay. Okay. So while doing the examination, you have to tell, can you close your eyes properly? Okay. So
Yes, sir.
just to check that he is at risk of developing corneal exposure. Or not. Then the mouth, you did very well, doctor. You rule out any oral pigmentation, neck, excellent, very good. You look for lymphadenopathy, congestive cardiac failure, critical myxedema, edema. Okay. So DD, you already know it. Okay. Orbital mass, orbital cellulitis, orbital fracture, myasthenia gravis. Clear, doctor?
Yes, sir.
Very good. And thyroid ophthalmopathy never will be bilateral symmetrical. Always be asymmetrical.
Yes, sir.
Very good. Diagnosis, investigation. So diagnosis is clinical.
Clinical diagnosis.
General investigation, you already know. You for Graves' disease and thyroid status, you have to do thyroid function test, anti-TSH receptor antibody, and anti-TPO. Investigation for thyroid eye disease, and to rule out any disease. Okay. So orbital MRI. Clear, doctor? Management, the patient education, counseling, multidisciplinary team approach. Thyroid eye disease is divided into two parts. One is active thyroid eye disease, and one is you can say means inactive thyroid eye disease. Clear, doctor? So what
Yes,
are the features of active thyroid eye disease? There might be scleral injection will be there,
Injection.
phimosis, periorbital
Hemostasis,
edema.
edema.
So these are the features will there. It means this patient has active thyroid eye disease. Okay.
Yes.
So active
Yes, sir.
thyroid eye disease, usually we are not doing any corrective surgery. Okay. So we will just treat a symptomatic treatment, artificial tear, sunglasses, iPad. If there is a diplopia problematic, we can give the prism. Okay. But we will not go for any surgery for diplopia, because it is the thyroid eye disease is active. Clear? And
Yes.
if the thyroid eye disease is active, we will not go for radioiodine therapy. Clear, doctor?
Yes, sir. Yes, sir.
Very good. Then the treatment of the optic nerve compression. It is a red flag, so it's an emergency. Okay, so any features of optic nerve compression required urgent medical attention and treatment.
Yes, sir.
Okay, so systemic steroid, you will give IV or oral methylprednisolone, surgical decompression or vital radiotherapy. Okay, if and corneal exposure, also a red flag. It's a medical emergency, so you will give the artificial tear, surgical decompression, steroid, same treatment. And there is a inactive condition that is called the burnout disease. Okay, so the burnout disease will have a stable sign. Okay, they will not have phimosis, periorbital edema or like this. Okay, in that stage, usually we are doing the corrective surgery.
Corrective surgeries.
Okay, and there are the few risk factors for thyroid eye disease, like female, middle age, smoking, and this HLA-DR. Okay, and Dr. Nigar, when you are addressing the patient concern, he's asking you, doctor, do I lose my vision? So you have to reassure the person.
Yes, sir.
Okay, that if you are on regular follow-up, and if you will have any red flag, and if you will get urgent medical attention, the chances of losing vision is unlikely, because this condition usually become inactive after few years.
Okay.
So usually 1 to 5 years, the thyroid ophthalmopathy become inactive. Once it become inactive, it will be remain like that.
Okay.
Just a minute.
Okay, sir.
Just a minute. Okay, doctor?
Yes, sir.
Very good. And also, sometimes patient will ask you surrogate that or patient that doctor, this the eye changes, I have this prominent eyes, they are correctable. Okay, so you can say that yes, once your disease become inactive, we can do the corrective surgery. Okay, and we will able to correct most of the means what is called you can till the most of the deformity we will able to correct.
By surgical procedure, we can revert back it.
Revamp.
Okay.
Very good.
Yes.
Okay, doctor.
Yes,
So
sir.
well done, Dr. Ansari. You are doing well. Okay.
Thank you, sir.
You will be the next in 160 plus.
Inshallah. Shukriya, sir.
Don't worry, we are hopeful. Okay, you can do it.
Yeah.
You can do it. Don't worry. Your preparation is
sir.
very good, excellent. You are very confident. Okay, when we are preparing, we are not confident like you. Okay, so don't worry. You will do very
Thank you,
well.
sir. Thank you, sir.
So anyone has any questions, or we will end our session today?
Assalamu alaikum, doctor. In case if there is papilloedema in ophthalmic fundoscopy, can we inform that we should admit the patient?
Yes.
Yes.
So if we will do the fundus examination, if there is an optic disc swelling or optic atrophy, it's a medical emergency.
Okay, and if and while examining the patient, should we visual acuity? If we know that it is the decreased visual acuity, also we should do admission.
No, then we will seek urgent ophthalmological opinion to find out why he has. But we will check it. Means we will do the fundus. Might be there might be optic atrophy.
Okay, doctor. And last question: should we mention in investigations CT or MRI for orbits, or no need? That will order
No.
by ophthalmologist.
No, CT orbit or MRI orbit is must to know the any periorbital fat, okay, or any swelling of the extraocular muscles.
Okay, so we should mention that in
the
investigations.
So first we will say the diagnosis of thyroid ophthalmopathy is clinical. However, I will do the test to confirm the thyroid status of the patient. I will do the MRI of the orbit to know the status of what is called orbit, okay, and the extraocular muscles. Okay, so in case if the patient has like his vision affected, can we mention urgent CT orbit, or that's not basis wise? No. Urgent ophthalmological is more important because it's required urgent steroid, not urgent surgery.
Oh, okay. Thank you very much.
So the treatment means it's a not surgical emergency. Thyroid ophthalmopathy is not a surgical emergency; it's a medical emergency.
Sir, in this situation, we
Excellent
need
point.
this case, we need to start on steroid. That will be oral steroid because it's not an emergency at this moment of time.
Yes. So those having a problematic diplopia, we can start steroid, and later on we can switch to some steroid sparing agent.
Sparing agent.
Okay. If it is means very troubling diplopia, otherwise if it is occasional, no treatment. And some advice you can give. Now I remember means anyone having thyroid ophthalmopathy, we will give the advice that while sleeping you need to put some eye pad, okay, to close your eye properly and elevate your head end of the bed.
Okay,
Clear?
sir. Yes, sir.
Very good. So anyone has any questions, or we will end our meeting? Or if anyone has any questions, we can discuss it in the eye cover.
Yes. Thank you, sir.
Okay, welcome. So there are the two types of medical emergency. One is due to optic nerve compression, and second is due to a corneal exposure, means involvement of the corneal ulcer, or it's a medical emergency because patient can lose vision due to this.
Sir, I have a question.
Yes, doctor.
Like this lady is already had been
Your voice
operated,
is
right?
not clear, doctor. If you can,
Hello?
it seems
it
like
clear
this
now?
not
Is it clear
very
now?
clear, not very clear, doctor.
It's still not
But
clear?
no. Okay. We can means hear it. No problem, doctor. Continue.
Okay, thank you, sir. No, my question is that as this lady had been already been operated for like for the thyroid gland, right? And
Yes.
so my point is that why she developed this, active eye disease now, in spite
Okay.
of the treatment?
Usually the antibody, doctor, they have thyroid receptor antibody.
Mm-hmm.
So these receptors are also there over the extraocular muscles.
Mm-hmm.
Okay, so that's why they also react with the. So even we did the thyroid surgery, we did not remove the antibody from the blood.
Mm-hmm.
Okay, so that antibody react with the eye muscles and they causes soreness, you can say inflammation and swelling of the extraocular muscles.
Okay, so it keeps
Okay.
triggering the eye problems actually.
Yes,
even
because
after
due to
years of the surgery.
because we remove the thyroid gland, okay, but
Yes,
still
got it.
antibody is there.
Okay, got
Okay,
it.
so thyroid receptor antibody is still there in the body. Okay,
Okay,
and the similar receptors are there over the extraocular muscles also. That's why these antibody react with that, and they can cause thyroid astigmatism.
okay. Thank you, sir.
Okay, welcome, doctor. So I think it's a long session, so we will end our. So thank you so much everyone for joining our session today. And so we'll have a session in coming week. We will try to be regular. We always promise, but we will not able to do it. So we will try to do it. Okay. So I will end our session.
Sir,
Yes.
one doubt actually I had.
Yes.
Like if in a case, not regarding this case, just in general, for communication station, if like for example, if there is a case of breast malignancy which was treated earlier, now the patient is presenting metastasis to the back, and your task is to explain the blood reports and further management. So, sir, in this scenario, do we need we have to supposed to take this case as a palliative care after breaking the bad news, isn't it, or we have to
Yes.
approach it differently?
No, palliative care.
Okay, just to explain the disease that it has spread now, and we have to go for the palliative care, and each and every component of palliative care we have to explain, including the advanced directive and everything, right, sir?
Yes, advanced directive, legal power of attorney.
Yes.
It depends upon the surrogate situation. If she is crying too much, okay, and it seems like she is unstable to absorb more further information, you can tell, because now there is no examiner question.
Exactly, sir.
So in my view, maybe examiner will think that you don't know about advanced directive legal power of attorney. Okay, so you can tell her that we need to discuss further something also. Okay, it seems like this is not the ideal time to discuss. So we will when we will meet next time, I will discuss something more about this.
Okay.
Okay, in my view,
Okay.
it's a better way. The examiner will know that only thing left is the advancce directive. So you want to talk in next meeting, not today.
Okay. Okay.
Okay, you can also say that we have given a lot of, or I have given you a very bad news. Okay, I feel very sorry for that. Okay, and I need to ask you something more about you, but we are going to discuss regarding this in our next meeting.
Should we mention the term that okay, the way sir you told is excellent, that yeah, we have discussed a lot. Okay, there is one more sensitive topic, but I'm not touching it today because I know it's too much to give it in a single go.
Yes. So we will when we will meet next time, we will discuss it. So anyhow, she is not going to die tomorrow, so you can discuss
Mhm.
it next day. No problem.
And sir, one question
But
with
if she
respect
is
to.
stable, if she is
Hmm.
stable talking to you, at the end, if you have time, you can also
Okay.
ask. Some examiner very strict, they mind it that why after giving such a bad news, candidate ask. Some they are
Mhm.
looking for that, so you don't know what type of examiner is there. But
Mhm.
the both are correct. Both are the correct way. So
Yes,
you
sir.
have to judge there. You have to
Mhm.
there on the basis of the situation. If
Sure.
if the surrogate is stable, you can ask also.
Yeah, if the surrogate is stable, we can just point like, okay, I want to talk regarding one more sensitive issue. Are
Hmm.
you okay with that? Then we can start
Very good.
the
Excellent.
thing.
Excellent.
And sir, with respect to another case, like if the patient, for example, there is a father who is unconscious at this moment of time,
Hmm.
and it's a kind of a breaking bad news patient that the father is on terminal stage, and we are talking to the son. At that moment of time, do we need to ask, like, do you want to accompany for any support anyone? Is it
Very good.
allowed, or it is the breach of
No,
confidentiality
very
at
good.
that time?
So very good question. Actually, the next of the kin, maybe 2 or 3 or 5, maybe more than that. Okay, not that
Yes.
only he is the next of the kin. Might be his sister also there who is waiting outside. She has
Mm-hmm.
similar right to the son. Okay,
Mm-hmm.
clear?
Okay.
Okay, might be he has one brother, one sister, and both are sitting outside, and they are
Mm-hmm.
also the next of the kin, and they have the similar right like the elder brother. Okay,
Yes,
you
sir.
can invite them. That would you like to invite any next of the kin who wish to accompany you?
Okay.
Okay, so you can do it also. If you will not do it, also no problem.
Okay. Okay,
Okay.
but you have to mention that word in
But
between.
you
Like,
can
do you
invite.
want to
There is no.
Hmm.
You can
Okay.
invite next of the kin only, because it is allowed that you can share the information with the next of the kin.
Okay, sir. Okay. So first of all, we'll confirm that the person we are talking to is the next of the kin, and then we can ask, is there anyone else who is next of the kin of Mr. This? And would
Ah,
you want me to ask them to in this them also in this discussion?
so they have similar right. Okay, so they
Yes,
can
sir.
sit together and you can talk to them. No problem.
Okay, sir. Thank you so much, sir.
Okay, well. So we will end our meeting today. Thank you so much, everyone, for joining our meeting.